Welcome, everyone, and thank you for attending our program, Feeding and Nutrition Issues in Autism. My name is Michael Morrier, and I'm the Program Committee Chair with the Atlanta Autism Consortium's Board of Directors. The Atlanta Autism Consortium is a nonprofit organization dedicated to creating collaborating conversations throughout the Metro Atlanta autism community and beyond. We host free programs just like this on a wide variety of topics, and we're so glad that everyone could join us tonight. I want to thank, before we start, I want to thank Dr. Nuhu and Dr. Whitney as outgoing chairs for the great leadership they've provided the AAC over the past 2 years. And I also want to thank Dr. Brasher for continuing the AAC's vision and mission as the new AAC chair. Her support as I take on the role as the program chair has been invaluable. Dr. Brasher also sends her thanks to everyone attending tonight and for supporting our programs. Before we start, just a few brief housekeeping notes. Please know that as an attendee, your microphone and camera will remain muted, but you can ask questions if you have throughout the program in the chat box at the bottom of your screen. Not all the presenters are going to be showing slides tonight, so after this presentation, we will share the presenters' slides and other resources that they talk about. Additionally, we will be emailing out the contact information for our panelists to the email address you used to register for the program so that you can contact them directly with any of the questions you may have. Tonight, we're going to be joined by Dr. Megan Wenzell of Case Western Reserve University, Mr. Michel Bordeau from Gene Therapy, and Ms. Kaitlin Gary from Biometrics. I hope I said all those right. Unfortunately, Dr. Lindsey Burrell was unable to join us due to a personal matter that has arisen, but she's created a video of her talk that we're going to start off with tonight. Her video and a recording of this presentation will be uploaded to the AAC's YouTube channel soon, so please stay tuned to our social media posts for notification of when these get posted. Again, I'd like to welcome you all. And first, we'll start with Dr. Lindsey Burrell. She's a licensed psychologist at the Atlanta Children's Center and owner of Burrell Behavioral Consulting. She received her doctoral degree in clinical psychology from Texas Tech University, completed her predoctoral internship and 2 years of postdoctoral fellowship at Emory University in the Marcus Autism Center. Dr. Burrell was an assistant professor at Emory and a licensed psychologist at the Marcus Autism Center and the Severe Behavior Clinic and Children's Multidisciplinary Feeding Clinic. She's also actively involved and has held leadership positions in professional organizations, including the Association of Behavioral and Cognitive Therapies and the Society for Pediatric Psychology. She provides clinical services through the Atlanta Children's Center, addressing moderate to severe behavioral and feeding challenges in children with and without neurodevelopmental disorders. And she specializes in parent-mediated intervention, is a certified trainer in the Ruby Parent Training Program, and provides training through Burrell Behavioral Consulting. So with that, I will share her video of her talk. She's showing her slides and she's up in the corner. If you have questions, as I said, we'll give her email out at the end after this presentation, so you could email her directly. So let me start sharing her.
Everyone, I apologize for not being able to be there with you today in person, but my name is Lindsey Burrell, and I'm going to be talking to you today about food selectivity and autistic children. So the thing that we can think about is how common is food selectivity or limiting the variety of foods that you're eating. And there is a really wide range from 30 to 84% of autistic children that have some sort of feeding difficulty. Now, this could include a whole variety of different feeding concerns that we'll actually see on the
Michael, it seems like the audio isn't working. Are you hearing that okay?
Fruits and vegetables, and sometimes we see this as proteins as well. So in this slide, you can see that when Mays and Zickraft looked at some different databases of children who were diagnosed with autism versus those diagnosed with ADHD, and then they further classified this in a different CASD standardization sample, which is a large database of gathering information on a wide variety of children with different diagnostic concerns as well as no diagnoses. So you can see that they looked at the differences between individuals diagnosed with autism, ADHD, with associated intellectual disability or not, as well as learning disabilities, language disorders, and then neurotypical children. So what we can see here is that children who were diagnosed with autism across both of these samples were more likely to report having some type of atypical eating behaviors. So 70% in one diagnostic sample, and then the other one as 68%. So we can see that that number is pretty high as far as reporting some types of atypical eating behaviors. And then when we take a look at what specifically those challenges were, you can take a look at this far right column that collapses the different standardization samples with the diagnostic clinic sample in one category so that you can see it here. And like I said, the most common is eating a limited variety of foods, or what they call here limited food preferences, with 88% of those combined samples reporting that concern. You can see these also in order here. The next concern was sensitivity to food texture, and then pocketing food or holding food in their cheeks. And then the remaining ones you can see here. And then if you take a look at the bottom, we see that most of these kids actually reported 2 or more of these concerns. So it's not always limited to just one type of feeding problem, but often there is more than one. So then we want to be able to think about, we know that there's atypical feeding behaviors, but we want to be able to distinguish between, are we talking about like picky eating that may potentially resolve on its own or with minimal intervention, or are we talking more about a feeding disorder? And so we can tell these things by looking a little bit more deeply into what specifically is going on. Both of these categories are going to eat a limited variety of foods, at least at some time, but we see more with picky eating that kids kind of fluctuate. So they may or may not accept foods from food groups or from all the food groups all the time, but there may be times that they do, and they may pick up foods and they may drop foods. They're usually a little bit more tolerant of the presence of non-preferred foods in their space. They're usually more willing to try foods. Usually their diet is going to meet their needs, even though it may be limited. It doesn't usually present with a nutritional concern. And their preferences can be influenced by their peers. So we may see that kids who just have picky eating may eat a wider variety of food at school. Or maybe if they're going to social outings with their peers, they may eat at those places. And they'll usually eat the foods that they like across settings. But we see that children who have more feeding disorders, those inflexible food preferences may change over time, but their variety is still limited. And they're consistently refusing one or more food groups that will likely affect their nutritional and medical status. Usually their behavioral response to the presence of non-preferred foods is quite excessive and extreme, really high intensity behaviors that are disruptive not just to the child, but to the family. And we see that this eating is disrupted across settings. These kids are not eating better in one location versus another often, and they may refuse to eat when they're hungry, even when offered their preferred foods in a different location. So this really differentiates children who have more of a feeding disorder from the kids that are just picky, because the impact of those feeding challenges are much more severe in those with a feeding disorder. And so then we think, well, what is this feeding disorder? And so today I'm going to focus more on avoidant and restrictive food intake disorder, which is an eating or feeding disturbance that's manifested by a persistent failure to meet appropriate nutritional and or energy needs. And so I think some key words here is persistent, meaning that this is continuing over time. It's not like those kids that I described as picky eaters that may kind of fluctuate. And it's affecting either nutrition, like there's likely some nutritional deficiencies, or they're not consuming enough volume and calories to be able to meet their energy needs. So this may be associated with weight loss or failure to gain weight appropriately. It may be nutritional deficiencies. It may be a reliance on feeding tubes or other nutritional supplements. And there's a marked interference in psychosocial functioning, meaning that, you know, they can't go other places, or they can't go on vacation, or they can't spend time with friends because they're not able to eat in those locations. Or maybe they're refusing to eat at school and they're going all day without food. This can look a number of different ways, but those are just a few examples. We also know that when we think specifically about autistic individuals with ARFID, the most often explanation for ARFID in this population is the intensity of the smells, the taste, the textures, all of the things associated with that novel food that may then influence, negatively sort of influence, whether or not they're going to eat that food. And so this is the area that we know, like I said, is often associated with our autistic individuals. And so that's an area of focus and intervention. And so some of the things that we have to think about here is that if we think about some of the characteristics of autism, those characteristics are going to influence feeding as well. So we often see those repetitive and ritualistic behaviors, and that can affect feeding in that they may want food to look a certain way, the packaging to look a certain way. We can't have bananas that has any dark spots on it. So they may have some very specific rules around foods. And even if it's a food that maybe they would normally eat, if it looks a little bit different or is prepared in a different way, they're likely to refuse those foods. Also, the sensory over-responsivity often seen in autistic individuals may also influence feeding, and that there may be certain textures of foods that are not acceptable to them. And then also the generalization difficulty that impacts food in a number of ways, including being able to eat in multiple places, being able to eat with different people, being able to eat when the circumstances change. So if you had someone visiting in your home, even though you would normally eat in your home, that may really disrupt the meal time such that the individual with autism may not be able to eat in that environment. And so one way of kind of thinking about this is if we take a look at these different apples, we can all look at them and say, these are apples, but they're also very different. They're different colors, they're different textures. If you were to try to eat these apples, they have very different tastes. So we can't just say that an apple is an apple, right? There's a lot of variety even within an apple. So when we think about this in these ways, you can kind of see a little bit more when we're talking about individuals with eating disorders, particularly those who are more neurodivergent are going to have difficulty in this way, because if something changes or is presented differently, then that may result in refusal. Some of the other factors that can contribute are if the individual also has underlying anxiety that may be affecting multiple different places in their life that also can influence eating, or disruptive behaviors. So whether we're talking about screaming, crying, throwing things, hitting, kicking, if those behaviors are occurring across different situations, they're likely also occurring during meal times, or may only be occurring during meal times. But these behaviors that we see more often in autistic individuals than the neurotypical population are also going to influence feeding. We also know that there's significant stress on the caregivers of individuals on the spectrum who have feeding difficulties. Meals are really stressful and chaotic. It may negatively influence that parent-child relationship and often actually results in restricting the family's diet as well. So then what can we do about it? So there's no way that I could really cover all of the different things that are important to consider in different treatment modalities in this really brief period of time, but I wanted to be able to provide at least some ideas of what treatment can look like when we go more of sort of that psychosocial behavioral route. And so what treatment may look like with a psychologist or behavior analyst or somewhere similar, some discipline similar to those. Maybe thinking first about getting the child to the table. Oftentimes, that is a significant challenge. Being able to first tolerate the presence of non-preferred foods. We may be also thinking about more of the tolerance from a texture standpoint, because we know that that is also a common challenge. And then working on the meal schedule. And often, you know, these goals may also be you may be working in collaboration with other disciplines to achieve these goals. So we might need to work on scheduled meals and snacks, potentially with a dietitian. We may need to be working on oral sensory motor tolerance with a speech language pathologist or occupational therapist who may be focused on feeding. But there's ways that, you know, when we think about intervention, where we're also going to consider, like, what are these short-term goals we want to achieve? And then the long-term goals are going to be more about expanding the variety of foods that we're eating, or additional skills like feeding themselves, texture advancement, those types of things. So as I mentioned, we want to kind of look at this in a very stair-stepped approach. So the very first thing that we need to do is look at being able to establish these foundational feeding behaviors. So we need to make sure that they will come to the table, they'll stay at the table, or wherever sort of is culturally appropriate for them to eat. They need to be able to tolerate the presence of non-preferred foods before we expect that they're actually going to try them. We need to set them up for success with a meal schedule that is going to promote hunger, so that they're more likely to eat during regularly scheduled meal times. And then once those things are in place, then we can kind of move on to thinking about what are some of the changes that we need to make to increase the likelihood of them trying different foods. And so that may involve praise and attention for eating the foods. It may involve like removing attention or limiting attention to any types of challenging behaviors associated with refusing food. We may be working on things that are minimizing the demands and making the bite sizes smaller, which we'll talk about too. And all of these things have to be in place again before we can move into the place where we're actually increasing the amount of food that the child is consuming of that new food, and then transitioning that into meals and then eating it across different environments. So when we first think about those foundational feeding behaviors, like I said, we may need to be creating like schedules and maybe in collaboration with the dietitian to ensure any sort of special needs that the child may have. So we're going to focus on these things first. And then we want to make sure that the meals that they are eating are going to be foods that are preferred, but that we're trying to get the widest variety we can within those preferred foods, so that we're setting them up for success and we're making sure that we're moving towards goals of adding in new foods that are going to be meaningful to their diet. So although we may have to start with some foods that are already in the, like, similar to those that the child is eating, we ultimately want to be moving towards following more of these choose my plate guidelines, where we have foods across different food groups. Then we want to be able to think about what are some of the strategies that we need to implement to reduce the likelihood of disruptive mealtime behavior. So we might need to reduce the bite size to make sure that it's something that seems more manageable and reasonable for the child, or reduce the portion size, reduce the expectation from the number of bites that the child has to take. We're only going to be focusing on one new food, not a whole variety of new foods. And then we may have to modify the food texture depending on if texture is a concern for that child. And so this is an example of what it might look like to modify the bite size. So this is just, I mean, to those of us who eat yogurt, this is not scary at all, most likely. But when we think about a child who doesn't eat yogurt, or any individual who is trying a new food, this size would still be really overwhelming. So then we would want to be able to think about how can we make that smaller and then increase that size over time so that we're gradually working towards getting to the full spoon, but we're starting with a more manageable amount, something that's reasonable for that child. And for some, that may mean that we can't even start with this much on the spoon, but it really just depends on where the child's at and being able to set a reasonable demand. This is another way to kind of look at it. So when we're talking about foods that are not that naturally smooth texture, we might need to start with a really small amount of, a piece of fruit or a piece of food, and then over time increase that expectation as the child is tolerating that. So we're not just going to jump from sort of the very bottom to the top. We're going to go this kind of stair-stepped approach to gradually increase. There may be times that we need to work on modifying food texture. And so for kids who maybe have a really hard time with chewable foods, we may have to work on purees first or chopping them up to make the texture much smaller. Or if you're working in combination with an oral motor therapist, again, an SLP or an OT, who has indicated this child actually has some chewing concerns, then we're going to need to follow those recommendations to make sure that we're introducing food that is safe to the child. We also may go with a reduced texture if we're just trying to increase exposure. And so again, if we need to make it so small, or the child prefers pureed foods, then those may be some reasons to start at the lower texture and then advance. So when we think about reducing disruptive mealtime behavior, we want to be able to think about what behaviors we want to increase, right? So those are going to be things like coming to the table, staying at the table, trying a new food, maybe using their utensils, and then reducing any inappropriate behavior. And so these could be using tools like differential attention or differential reinforcement, where we are, providing praise and attention to those appropriate behaviors, and then removing or limiting attention to those inappropriate behaviors. And then that last part is to be able to expand the dietary variety. And so as I said earlier, we want to be able to start with a reasonable expectation. And so if we think about this as broccoli is the non-preferred food, goldfish crackers is the preferred food, this is one way to consider introducing food. So like we have the things that they like, so we're also providing breaks in between bites of the non-preferred food, where we have that momentum going. And then the expectation is really small. It might just be one bite of that non-preferred food. And then once they get comfortable with that, are accepting, chewing and swallowing that bite without any difficulty, then maybe we can increase it to 2 bites. Or maybe we're increasing the size of the bite, but we're not increasing so quickly that the child is then going to start to refuse the food. So we want to be really mindful of moving their pace. And we may also want to include things like choice, like being able to give them the option. Do you want to work on broccoli or carrots? Or do you want to work on chicken nuggets or chicken fries? So that they are able to have some input if they're able to do that. And then, also being able to show them, like, first you did this, then you get this preferred thing, which in some situations may be a preferred food item. Some situations it may be a tangible reward, or it may just be social attention. So I don't have, again, a ton of time to go into all of these, but I wanted to at least show some different forms that can help be able to reach an individual's goal. So this demonstrates the number of target foods that were being worked on over time. This was not at one time. We don't want this to be extremely overwhelming. And then what the expectation is in each category. And then being able to kind of increase as they make progress. So you can see here with the hot chocolate, they were already at the goal of being able to drink 1 cup. Whereas these other things are starting at a smaller goal. And then once they achieve that goal, then we would kind of move on to our next step. So in this situation, you would be identifying, like what day of the week they did this practice, was it successful or not? And then after they're demonstrating consistent success, then you would move on to the next expectation. Until ultimately we're getting to the place that we want, where that food item is actually filling up a category on the Choose My Plate. So we don't want to just stop with like 1 almond or 3 almonds, because that's not going to actually count for like meeting their nutritional needs in that area. So we want to be able to continue to increase volume. And then we want to be able to increase and decrease demands depending on the child's behavior. So if their behaviors are really intensified, they're refusing to take the bites, they're screaming, crying, that tells me they're not ready. And we might even need to take a step backwards to be able to get them to the point where they're comfortable, and then we can move forward. But if they're taking the bites, they're swallowing, they're doing really, really well, and there's no indication of challenges there, then we want to be able to gradually increase over time. And then once we've done all of those things, then we get to that final part where we're able to then combine these different food groups together to then be able to have a more balanced diet that includes foods from all of these different food groups. And these are just different forms that you might be able to show, like what the different options are from food categories to give kids more choices when that's appropriate, and to be able to make sure that you're actually hitting all of those different food categories within a meal. And so, again, just to kind of summarize this, we know that these significant feeding concerns need some sort of intervention to address the nutrition, medical, and or psychosocial concerns. We want to be able to start with establishing those foundational feeding skills, then moving into reducing those mealtime behaviors so that we're setting them up to be able to start trying these newer foods, and then increasing that so that we're then focused on expanding variety, and then eventually generalizing those to meals, different people, different environments, so that we're able to have a larger impact. So I appreciate your attention to this. If you have any questions, you can email me at burrellbehavioralconsulting@gmail.com, and I will get back to you as soon as possible. Thank you so much. Bye.
Okay, thank you. That was a great video to open with, and I appreciate her sending that, even though she wasn't able to attend for us. Building off of that, our next presentation is by Dr. Megan Wenzell, who is an early stage tenure track professor at Case Western Reserve University, Francis Payne Bolton School of Nursing, and an emerging sleep disturbance expert in children on the autism spectrum. We'll have to have you come back when we talk about sleep, because that's also a big issue. During her postdoctoral fellowship at the Marcus Autism Center at Emory University School of Medicine, she led and collaborated on numerous projects related to food selectivity and bone density in children on the autism spectrum with the Multidisciplinary Feeding Program in Children's Healthcare of Atlanta. And now we will hear from Dr. Wenzell.
Okay. So I'm trying to hold on one second. Here we go. Okay. Can you see the slides?
Yes.
Okay, perfect. So hello everyone. Thanks for inviting me today to present. I'm really excited to be here. I'm now in Cleveland, but definitely missing the Atlanta weather, of course. But I'm a new tenure track assistant professor at Case Western in Ohio. And today I'll be talking about food selectivity, nutritional status, and bone health in children with autism spectrum disorder, which I will refer to as autism throughout the presentation. So I do want to acknowledge my multidisciplinary team who helped create or just have success in these projects. And I'd also like to acknowledge our funding source, the Marcus Foundation at Emory, who supported both projects, and then I have no conflicts of interest to disclose today. So a quick introduction about myself. I'm an early career pediatric neuroscientist and focus mainly on sleep and feeding in children with autism. So I really began my interest in my undergraduate career, where I worked with a sleep scientist in Nashville, Tennessee at Vanderbilt. And then after that, I pursued a PhD in nursing and had the wonderful opportunity of working with the Cleveland Clinic Children's Center for Autism. And then I really wanted to learn more about the special health needs in children with autism. And so I did a clinical job working at a residential autism treatment facility in Ohio. And then that led me to pursue further interest in a postdoc position at Emory in the Marcus Autism Center, which was a wonderful experience. So most of the research I'll present today will be research from my postdoc at Emory. So given the audience today, I won't go too much into detail about autism. However, we do know that children with autism have coexisting health factors, and the one that we're focusing on today is feeding problems. And so the range, and Dr. Burrell's presentation mentioned this as well, is very wide. It's 50 to 90%. And it really depends on the sample of children that were included in the project, as well as the assessment method, and then how you're kind of defining that food selectivity. But food selectivity is the most common feeding problem in the autistic population, and it often begins in early childhood and may persist into school age and adolescence. In building off of Dr. Burrell's presentation, food selectivity is really more than just picky eating. It's marked by sensory sensitivities concerning different textures, appearances, or smells, sometimes strong resistance or outright rejection of new foods, and then also disruptive mealtime behaviors, like she mentioned. And then while some symptoms of food selectivity are common in neurotypical populations, food selectivity in children with autism is more prevalent, severe, and recurring. And so persistent food selectivity is associated with stunted growth, nutritional inadequacies, limited dietary or food variety, can also lead to reduced bone mineral density, and then functional impairments in the child, and can have negative impacts on the family and the parent-child interactions and parental stress levels. And so today I'll present findings from two different studies that I conducted as a postdoc at the Marcus Autism Center. The first was recently published in the Journal of Pediatrics, and I did provide both articles for the audience free of charge, so you can reference those if you're wanting more information about them. So in the first study, we enrolled children from a high-volume outpatient autism clinic using a multidisciplinary team approach and validated parent ratings, which is the current consensus among pediatric feeding disorder experts. And really the purpose of the study was twofold. The first was to estimate the prevalence of food selectivity in a sample of children with autism who were not selected for food selectivity. And the second was to evaluate the demographic and clinical correlates of children with autism and food selectivity. So we included children aged 2 to 10 diagnosed with autism at Marcus Autism Center. Our trained research team contacted eligible families by phone or email. We scheduled an in-person multidisciplinary team assessment, and we were able to provide this at no charge to families, which was wonderful. And sometimes the waiting list for these kinds of assessments are anywhere between 8 months to a year. So that was exciting about the project. But what that assessment includes is a pediatric nurse practitioner assessment, a psychologist assessment, and then a dietitian collected information about the child's medical and psychosocial histories, as well as their dietary habits. And the dietitian completed a 24-hour dietary recall to record their dietary intake percentages below 80%. And then parents rated the child mealtime behaviors on we call it the BAMBI, it's the Brief Autism Mealtime Behavior Inventory, and then disruptive behaviors on the Aberrant Behavior Checklist. And then we collected height and weight measurements by a trained research staff member at the clinic. And then we used logistic regression and multivariable modeling to evaluate the different clinical correlates associated with food selectivity. So we defined food selectivity in this sample by children who consume 2 or fewer foods in 1 or more food groups, and that was based on a 24-hour dietary recall. and then parents who rated that their child was never, rarely, or seldom willing to try new foods. And then children who met one of these criteria but not both, and those who did not meet either criterion were classified as having no food selectivity. So we looked at, the sample included 103 children. They were predominantly non-Hispanic males with a mean age of 6 years. And then over 50% of the sample was Black and had an IQ below 70. And then over 50% received Medicaid benefits. 1/3 lived in a single parent home. And then mothers were the primary informants. And the top medical problems reported by parents in the medical history were constipation and gastroesophageal reflux disease, or GERD. And overall, our results suggest that approximately 46% of children with autism had food selectivity in the sample, and then 54% did not. There were no differences in demographic or clinical characteristics, which we found interesting, and I'll explain a little bit more in detail later. But however, as expected, we did find that children with food selectivity had significantly higher mealtime behaviors, and specifically in the subscales of food selectivity, mealtime rigidity, and food refusal. And then what was interesting is that we also found children with food selectivity had higher scores for hyperactivity noncompliance on the aberrant behavior checklist compared to children without food selectivity. And this was interesting because it wasn't across all of the subscales, but it was only for hyperactivity. And then we went a little further with the results in the binary logistic regression after we adjusted for demographic and child level variables, including things like the child's age, sex, maternal employment, and IQ. Our results showed that mealtime behaviors in the hyperactivity non-compliance subscale were both significantly associated with the child having food selectivity. And for mealtime behaviors, the odds of being in the food selectivity group increased by about 2 for every half standard deviation increase in the mealtime behavior score, and we found that to be clinically meaningful. So you don't need to know exactly what that half standard deviation is, but that's a meaningful change in that subscale. So, and then the same is true for disruptive behaviors. The odds of being in the food selectivity group increased by about 1.5 for every half standard deviation increase in the hyperactivity non-compliance. So overall, the dietitian results suggested that the most common omissions in the sample were fruits and vegetables, which is consistent with the literature, and that's what we typically see. We didn't find, very interesting finding was that we didn't actually find any differences in height, weight, or nutrient intake below 80%. And I will go into this on the next slide. Overall, in our study, growth and nutritional impairment were not elevated in the food selectivity group. It may be that children who refuse all dairy may have insufficient calcium and vitamin D, but may not be deficient in vitamin A and E, suggesting that the intake pattern may vary. So that could be a potential reason why we didn't find differences. And then also, given the age of our sample, we had a pretty young group of children, and the duration of food selectivity, and maybe that the nutritional deficiencies have not yet emerged. And so that would be something that future studies should kind of do more research to extend those findings. And overall, food selectivity was not associated with disruptive mealtime behaviors outside of mealtimes, except for hyperactivity noncompliance, which is a new finding that hasn't been reported in the literature. So overall, in the study, a few limitations is that, and I kind of consider them to be strengths, but we predominantly had a large urban population, a high percent of Black families, and children who were on Medicaid. And then children were predominantly less than 6 years of age, which could be why we didn't see the adverse health consequences of nutritional inadequacies. And then we also used a dietary recall, which does introduce some bias and may not be representative of the dietary intake patterns over time. However, we did have many strengths as well. It was a non-biased ascertainment method, meaning that we included children who were not selected for feeding problems. So they were just children who've been diagnosed recently, and they were able to kind of get an early assessment. So that's how we recruited the children. And we also had a very clear definition of food selectivity, which could be replicated in future work. And really, the next steps would be to replicate and extend our findings in larger, more diverse samples of children with autism and food selectivity to confirm the prevalence estimate here. And so next, I want to review a second study that we just published in the Pediatric Nursing Journal. And this was a feasibility study of nutritional status and bone health in children with autism with food selectivity. So we found that prior studies have examined bone mineral density in children with autism. However, these studies did not focus on children with autism who also had co-occurring food selectivity. So in light of this gap, the purposes of the pilot study were really twofold. The first was to evaluate the feasibility of assessing bone mineral density in children with autism who also had food selectivity. And the second was really to explore preliminary associations of food selectivity on bone mineral density outcomes in children with autism. So this study only included boys. They were aged 6 to 11 years. Unfortunately, we had to exclude girls due to the potential effect of estrogen on bone mineral density for girls who are entering puberty. So that's definitely something to do in future work. But we had two groups, the first being 10 children with a mild to no food selectivity, and then the other group was 10 with moderate to severe food selectivity. And families completed 2 in-person study visits. A dietitian completed a 3-day dietary recall to estimate vitamin D and calcium, and the food selectivity screening tool was used to estimate the consumption of fruits, vegetables, dairy, protein, and grains. And then we also collected height and weight on these children, and we did blood laboratory testing to assess vitamin D and calcium. And then we did lumbar spine and total body less cranium DEXA scans to measure the children's bone mineral density. And then we looked at mean differences between groups in nutritional status and bone mineral density markers with 2-tailed t-tests and effect sizes. So children who consumed 3 or more food items from each food group were classified as having mild to no food selectivity, and those who consumed 2 or fewer food items in 1 or more food groups or rejected food groups were classified as having moderate to severe food selectivity. So we looked at 20 boys. They were predominantly non-Hispanic with a mean age of 8 years. 50% were Black, and about 1/3 had a history of fractures. And 70% had asthma. 22% were taking a multivitamin in the mild group, and 57% were taking a multivitamin in the moderate severe group. And I'll go into more details about multivitamin use in the discussion. So then we looked at mean values for calcium and vitamin D, and we found that they were lower in the moderate severe group than in the mild group. And then, however, we didn't find any differences in dietary or biochemical indices. However, what was interesting about this is that both groups were less than 80% of the recommended dietary intake for both vitamin D and calcium, and both groups also had low serum vitamin D. So for DEXA and bone mineral density data, a similar number of children in both groups reported a prior history of fracture, and then all 4 DEXA markers showed large effects, suggesting that lower bone mineral density in the moderate severe group compared to the mild to no food selectivity group. And the difference in total body BMDZ scores were significantly lower in the moderate severe group. And then overall, this was a feasible study in the autistic population. We had a pretty high successful rate of data collection. So we did find 70 to 90% of children were able to comply with the study procedures and protocols. We definitely had some kind of sensory friendly ways that we were able to help children get through the DEXA scans and gave them extra time and practice and things like that. And then, although we didn't find any differences, both groups were less than 80% recommended dietary intake and had low serum vitamin D. And then children with autism and moderate severe food selectivity had lower total body BMDZ scores than children with autism and mild food selectivity. And then our results ultimately supported that there are adverse effects of moderate severe food selectivity on bone mineral density and bone health in children with autism. And then food selectivity in children with autism, like I mentioned before, is really a pattern of restrictive eating that's well beyond picky eating. The omission of food groups high in vitamin D and calcium increases the risk for nutritional deficiencies and reduced bone mineral density. And then while our results are promising, there are a few limitations, of course, to consider with a very small sample. We didn't have a comparison group. Originally, we did intend to have that group, but unfortunately, due to COVID, we had greater than 50% missing data and had to exclude them just due to the pandemic and not being able to get complete measures in that group. And then another thing that I mentioned prior was that children taking multivitamins were not excluded, and that could have influenced our findings. And what was interesting is that parents would often say that their child wasn't taking a multivitamin in the screening call, and then later at the clinic when we did the in-person assessment, they were taking a vitamin. So we just had no way of really excluding those children, and so many kids are on multivitamins. So it's something to consider in future work. That's important. And then given the high prevalence of food selectivity in this population, we definitely need more work and research in this area to further extend our findings. And let's see, I offered both manuscripts for you to keep, and I'm happy to answer any questions. Here's my contact information. And then if you want to connect with me, you can also scan the QR code and follow me on LinkedIn or X. Thank you.
Okay, that was a great, Megan, thank you. There was a question that came in regarding your first study, in that the cohort was majority male. So anecdotally, did you guys see any differences in male or female behaviors going through?
Yeah, so food selectivity, we did look at the demographics and like age, sex, those things, and we didn't find any difference between male and female. So it was interesting. I was expecting even a different socioeconomic status. Like I thought there would be a difference. So I was shocked when I saw that across the food selectivity groups there was no difference. But yeah, I think it is still something to consider because there could be, potential effects of the sex of the child. And it's really important. So.
Okay. Thank you. Thank you again for sharing that information. It was very interesting. So next, we have the pleasure of having Ms. Kaitlin Gary, who is a certified nutritional consultant who specializes in addressing the challenges faced by children with autism and other neurodevelopmental disorders. Utilizing in-depth lab work, she's able to create personalized nutrition plans and supplement regimes to optimize physiological health, resulting in improved functionality and quality of life for her clients. She's also the mother of a child on the autism spectrum, and her unique blend of clinical and personal experiences lends to her relatable and practical approaches. After studying under a prominent MAPS physician for 5 years and earning her credentials, Kaitlin launched her own nutrition practice in 2023, and she now helps children around the globe overcome their developmental challenges. So we are uniquely qualified to hear Kaitlin tonight, so I'm really excited.
Well, thank you so much for the introduction, Michael. Thank you all for being here, and thank you to the consortium for inviting me. Again, my name is Kaitlin Gary, and as Michael said, I am a certified nutritional consultant specializing in neurodevelopmental disorders, with the vast majority of my clients being children and adolescents on the spectrum. More importantly, I'm also the mom of 3 spectacular boys, one of whom used to carry a diagnosis of level 3 autism. Now, as others have mentioned tonight, Dr. Burrell and Dr. Wenzell, and thank you for those great presentations. The term picky eater utterly fails to capture the profoundly restricted and avoidant feeding issues that I have faced with my own child and now help my clients navigate on a regular basis. And this kind of next level selectivity and outright refusal of foods, as we've already heard tonight, is better known in the mental health community as ARFID. And ARFID is a relatively new condition in the DSM-5. And with this, the existing literature reflects a widespread sentiment that there remains much to be understood about the possible causes and treatment options for this disorder. And this is precisely where I hope to shed a little bit of light tonight. So currently, the prevailing view suggests that the underlying causes of ARFID are linked to mental health disorders, namely anxiety, obsessive compulsive disorder, phobias, and sensory processing issues, all of which are notably common among autistic individuals. So while the importance of addressing ARFID symptoms from this psychological standpoint cannot be overstated, I have found that restricted and avoidant eating patterns can also have roots in a range of physiological conditions, many of which are, again, more prevalent in autistics. By investigating and tackling these physiological components of ARFID alongside a mental health-oriented strategy, I have observed a reduction or total eradication of ARFID symptoms in numerous clients, which suggests to me that a broader application of this tandem approach could lead to more effective treatment options for those impacted by this disorder. So tonight, my aim is to guide you through the physiology of ARFID, highlighting a few of the fundamental biological mechanisms potentially associated with this condition, all supported by relevant literature, which is going to be provided to you all in the form of PDFs. Sorry, I don't have my slides together. Additionally, I'm going to explain how I have applied functional nutrition to assist my clients and my son to not only broaden their dietary choices, but also enhance their level of functionality and their quality of life. One of the first areas that I investigate when working with a highly self-limited diet, and I saw some mention of this in the comments this evening, is food allergies and sensitivities. Now, most people think they would recognize if they or their child had a food allergy. However, this assumption is not universally valid, particularly among autistic individuals who frequently exhibit a dysregulated or modified immune response. Time and time again, I shock parents with unexpectedly positive allergy results, even though their child has never exhibited any visible reaction to food whatsoever. This makes food allergy testing all the more crucial for those who are nonverbal and cannot articulate their internal experiences. And keep in mind, an allergic response for people on the spectrum often manifests as a seemingly completely unrelated issue, such as abdominal pain, constipation, diarrhea, eczema, or even anxiety, as opposed to the typical histamine type responses we would expect, like sneezing, hives, and facial swelling. And this resulting kind of simmering digestive discomfort and heightened anxiety associated with the latent allergic reactivity commonly serves as the culprit for an individual who adamantly rejects certain foods or food groups, or just has a generally low appetite. This was part of the issue for my son, who had dozens of low-level IgE food allergies, much to my surprise. And we're going to delve deeper into his story in a bit. So after discovering the presence of a food allergy, the trigger food does need to be removed from the diet for at least a period of time. And while this may seem counterintuitive to be removing foods from an already heavily restricted diet, this period of avoidance is designed to allow for a reduction in immune reactivity and systemic inflammation, which equates to less pain and anxiety for the individual, along with an increased willingness to consume and explore food. Most mild IgE-mediated food allergies and virtually every IgG-mediated food sensitivity can be successfully reintroduced back into the diet following this period of avoidance, especially if work is done to regulate immune function and rebalance the flora of the intestinal microbiome during this time. Which leads us right into our next physiological driver of ARFID, digestive issues and poor gut health. Upwards of 90% of children on the spectrum also experience gastrointestinal issues at a 3-fold rate of the neurotypical population. I am seeing chronic, sometimes debilitating issues like constipation, diarrhea, reflux, bloating, nausea, and/or cyclical vomiting in almost every single one of my clients with a diagnosis of autism. And just as we discussed with the food allergies, this ever-present digestive discomfort fosters a negative association with food, inevitably resulting in an unwillingness to eat. I'm really not sure how we could expect anything else if we simply dismiss these issues and only address the behavioral aspects of food refusal. Does anyone really feel like eating when they're constipated or having stomach pain? I know I don't. And the same goes for the clients I see. The problem is many of them feel this way every single day. So in order to overcome these issues, it is pivotal to understand that the very framework of the microbiome itself is often at the helm of chronic GI symptoms. And beyond this, can influence behavior, heighten anxiety, and directly contribute to ARFID. I dig into gut health with comprehensive stool testing for every person I see on the spectrum, which almost always reflects a significant overgrowth of intestinal yeast, especially in those with a history of antibiotic use or a highly processed, sugar-laden standard American diet. Yeast and fungi are among the most prolific life forces on the planet. Their primary function is to exist. So when colonized in the GI tract, they release metabolites that signal the brain to crave sugars and carbohydrates so that their continued life is ensured. Obviously, this can connect to selective eating. And I assume intestinal yeast colonization is an issue anytime I see a client that only wants breads, chips, and sweets in their diet. Bacterial overgrowth of both the small and large bowel is also commonly uncovered through stool testing for my clients with ASD and ARFID. One of the most prevalent forms of bacteria I see overgrown to an imbalanced or even dysbiotic state is Streptococcus. True, this bacteria is an expected inhabitant of our microbiome, but when present in exceedingly high amounts, it has been linked to OCD behaviors and increased rigidity. Now, with obsessive and rigid thought patterns being so intimately intertwined with ARFID, the potential link between strep bacteria and restricted eating is abundantly evident. Food addiction is another pervasive yet little known byproduct of poor gut health that often perpetuates this problem of restricted eating displayed by those with ARFID. The addictive properties of refined sugar are fairly well known and described as comparable to those of cocaine. So it probably comes as little or no surprise to you that high fructose diets can breed neurochemically driven dependencies on sugar, which of course appears to us on the surface as selective eating. Beyond this, however, lies another facet of food addiction that you've likely never heard of: the morphine effect. Now, I want you all to imagine that some of the foods that you consume every day are releasing opioid peptides when degraded in your digestive tract. Now, imagine what you might experience if these peptides were to somehow enter your bloodstream and attach themselves to the opioid receptors all throughout your body and brain. Perhaps you'd feel a sense of subtle euphoria and a dulling of your everyday aches and pains. And once that effect wore off, I'm willing to bet you would want to consume more and more of the opioid-producing foods, even if only on a subconscious level. Well, this is actually the case for two of the most ubiquitous foods in our diets, gluten and dairy. And while these foods are not inherently bad, when introduced into a faulty digestive system, the food-derived opioids can cross through a compromised intestinal barrier, entering into circulation to create the systemic afterglow and dulling of the senses that we just imagined for ourselves. This cultivates a true, full-blown addiction to these foods. And I see the evidence of this frequently in my line of work, in the form of autistic children who will not eat anything except for mac and cheese and chocolate milk, reacting with great veracity should they be denied their painkillers of choice. For this reason, when I'm working with a child with ARFID, I always ask myself, how much of this is restrictive eating versus addictive eating? And this is really just the tip of the physiologic iceberg, but hopefully it provides a sufficient understanding of how physical and immunological imbalances in the body can influence food-related behaviors, especially in a subset of the population that is more prone to mental health disorders and chronic digestive issues alike. Now, the beautiful thing is, there is so much we can do to optimize physiological health and correct these imbalances. And even more exciting is the fact that when I approach ARFID in a calculated manner that addresses both the mental and physical aspects of the disorder, children on the spectrum don't just improve the quality, variety, and nutrient density of their food intake, but typically become less anxious and rigid in every other area of their life, paving the way for the bonuses of improved cognition, speech, sleep, and socialization. And to back this up with a real-life example, I want to introduce you to Caleb, who is a 6-year-old boy that I began working with last year. And he carries diagnoses of both ARFID and ASD. When Caleb's mom first reached out to me, he was on a wait list for specialized feeding therapy and was already working on his feeding issues in ABA and occupational therapy. I want to read to you from the first food journal that was submitted to me upon Caleb's intake appointment. Day 1, breakfast, lunch, and dinner. Pizza Hut hand-tossed pizza, crust only, cheese and pizza sauce are scraped off, eats an average of 6 to 8 slices per meal, depending on how thick the crust is. This exact same entry is submitted for days 2 and 3. Clearly, Caleb refused to eat anything except for Pizza Hut at every meal, only if most of the cheese and sauce were scraped off. And this was literally all he consumed, aside from snacks given during therapy and Pediasure given at bedtime. Now, here is a list of the main issues Caleb was struggling with apart from his speech and social delays at that time in May 2024, taken again directly from the intake questionnaire filled out by his mother. What are the biggest issues affecting your child at this time? Anxiety, chronic constipation, food aversion, eczema, food and environmental allergies. These symptoms sound hauntingly familiar. A thorough workup was done for Caleb, including comprehensive stool testing, blood allergy testing, and organic acids testing. Unsurprisingly, a severe overgrowth of intestinal yeast was discovered. However, what I did not expect to see were anaphylactic class 6 allergies to gluten, dairy, and egg. It is almost unthinkable that Caleb had only consumed foods that he was severely allergic to for years with no notable acute reactivity. I got Caleb started on magnesium, digestive enzymes with meals, probiotics, along with an antifungal regimen. From a nutritional standpoint, I worked with Caleb's mom to develop a dietary plan designed to gently ease him away from Pizza Hut into other less inflammatory forms of his preferred food that did not contain allergenic triggers nor the slew of chemical additives. As with all of my clients, we worked within Caleb's preferences and limitations, and in less than 30 days, Caleb was off of Pizza Hut altogether and had eliminated the vast majority of gluten, dairy, and egg from his diet. Caleb's most recent appointment was just a few weeks ago, and his mom reported that he is now willingly adding protein sources into his diet for the first time, as well as some fruits and vegetables. He is open to tasting almost anything and politely verbalizes his dislike instead of throwing fits. Caleb's eczema has improved. His constipation has improved. But above all else, he is now articulating his thoughts and feelings on a new level and was able to tell his mom that he didn't like one type of sausage he tried because it was too spicy. He also demonstrated significant advancements in both cognition and comprehension, to the point he communicated to his mother that he recognized gluten was detrimental to his health, and he agreed he should not consume it. And these are life-changing improvements in a relatively short time, and I am so excited to see where Caleb goes from here. But this does leave a rather weighted question hanging in the balance. How many other children out there with feeding issues have severe allergies that no one is aware of or even testing for? And now for the anecdotal tale nearest and dearest to my heart, my son, Silas. As I mentioned at the top of this presentation, he was diagnosed with severe autism at age 2.5, and he spent the first 3 years of his life in a state of sheer misery that still wrenches my spirit when I allow myself to remember it. He was never formally diagnosed with ARFID, but he had coned his diet down to a handful of foods that he would sometimes eat, as long as they were room temperature and not a soft texture and didn't have any sauce on them and weren't mixed together on his plate. Just around the time he received his autism diagnosis, Silas was completely nonverbal, had fallen off of the growth charts, screamed and cried all day and night, and was considered a danger to himself due to the level of his self-injury. In a panicked state of desperation, I found a functional doctor and started the diagnostic investigation, revealing the dozens of food allergies, along with elevated strep antibodies, several nutrient deficiencies, and significant overgrowths of both strep and candida in his digestive tract. Once I had begun to wrap my head around the fact that my son had an allergy to literally everything he ate, I took on the daunting process of eliminating these foods from his diet one at a time. But to my pleasant surprise, with each food I removed, he seemed to naturally add other foods back in, even the ones that he used to vehemently reject. So I kept going, and Silas kept improving. I corrected his nutrient deficiencies, reduced the strep and candida, fostered his gut health, removed refined sugar, and on and on. And over time, the restricted eating gradually dissipated into a state of non-existence. These days, Silas is now a happy 10-year-old with the most diverse and adventurous palate imaginable. And the same fluidity and flexibility that allows this to be so has permeated the rest of his being and spurred his developmental progress by inconceivable measure. Today, my child, who was never supposed to speak a word or potty train, is fully conversational, easygoing, adaptive, social, and energetic. He attends 4th grade in a mainstream classroom and is blowing the limitations placed on him in his early life completely out of the water with every passing day. Last week, Silas got 2nd place in the school-wide spelling bee. And he would have gotten first if they hadn't given him an obscure and poorly enunciated word in the final round. He rides his bike to school, looks after his little brother, and meets up with the neighborhood kids for Nerf battles. Silas got his childhood back. Silas got his childhood back. He also got his future back. What initially seemed like an unlikely pipe dream slowly cemented itself into our everyday reality, instilling me with a newfound mission in my life. And it's this mission that has brought me here tonight, with the ultimate hope of guiding others to the same seemingly impossible reality that was gifted to my son. I know that all of you here, in the spirit of the consortium itself, share this driving desire to help those on the spectrum to be healthy, happy, and fulfilled in their lives. And I think the realization of this common goal requires a relinquishing of a collective rigidity that greatly supersedes restricted eating habits and has shaped our compartmentalized view of autism itself. Whether a parent, a medical practitioner, a therapist, or autistic, by coming together and combining our efforts to form a multi-dimensional approach to spectrum-related challenges, we can put so many childhoods back into the hands of their rightful owners, where they belong. Thank you.
Thank you. That was very interesting and informative. Someone did ask if your testing included testing for celiac disease as well, or is that...
We usually test for gluten allergies and sensitivities. There are some more in-depth tests that we can utilize to look for actual celiac, but it is a different mechanism, being an autoimmune condition as opposed to an allergy. But yes, that is absolutely something we can test for.
Okay. Thank you. And again, we will provide Ms. Gary's, I always want to call you Gray for some reason, Gary's email address. So if you have questions specific about your situation or your child's situation, you could email out to her for that. And our final presenter, Mr. Michel Bordeau, is a psychotherapist and functional nutritional coach who has 10 years of experience in private practice. He serves on the board of directors of the Georgia Neurodiverse Chamber of Commerce, which I just heard of tonight for the first time, and has previously spent more than 15 years as a university lecturer and academic counselor. He specializes in working with adults and adolescents on the autism spectrum, as well as addressing eating disorders, anxiety disorders, and professional burnout. He's trained in CBT, TFCBT, DBT, and Lego therapy. He employs evidence. Oh, Lego. Sorry,
Lego.
I read it as Lego. Sorry.
I would love to make Lego therapy. Would be great. You know,
I was interested in Lego therapy.
Yeah, I love that.
He employs evidence-based techniques to foster emotional resilience and well-being. He also provides life coaching for parents of adults with autism and helps families to achieve growth and balance. Welcome, Michael, and we are interested to hear what you have to say.
Okay, so my name is Michel Bordeau. I'm originally from France. I'm a therapist here in town. I'm also have a coaching practice, which is between Atlanta and San Diego. I work primarily with neurodivergent individuals, you know, from ADHD, ASD. I work also with individuals who have disorder of eating or eating disorders and body image, such as body dysmorphia. I spend a lot of time with adults on the spectrum, helping them with, you know, making a difference in their life, trying to start to become adults. Adulting is a very challenging moment because the resources are not always there for individuals who leave high school or even leave college. One of the reasons why I'm on the board of director of the Georgia Neurodiverse Chamber of Commerce is because we're going to try to put a lot of effort into bridging all the resources for adults on the spectrum and their family, because as much as there are resources from age 0 to 18, it seems that there's a huge drop after age 18. So a few years back, because of my own experience, I'm also on the spectrum. I was diagnosed at age 47 Until then, I thought a part of me, and this is the language I deployed to myself, was profoundly crazy, because I had habits that were very odd and very noticeable, clinically significant, meaning they affected my relationship with people, they affected my health, they affected my way of working, for instance. I had reached a point where I was very heavy for my standards. I was 65 pounds heavier, and realized that there was some correlation between the weight, because and also obviously the food I was eating, but also the medication I was taking. So this is very common with adult on the spectrum. There are many factors where food has become a problem when we are in our 30s and 40s. And now with my client, I see it in the 20s. So we're more prone to obesity. That's one thing for sure. We're more prone to cases of pre-diabetic. We're often more sedentary, and therefore that exacerbates all of these problems. I see a lot of disorder of eatings, a lot of eating disorders as well. And all of this is hard to address. And I will tell you, this presentation has 3 axes. I'm going to talk about the nutrition habits and habituations of adults on the spectrum. And we've already heard some of these problem with feeding problems, but they continue into adulthood. And actually they are exacerbated because then the adult has the responsibility for their own feeding. And I'll explain more on this in a minute. The other thing I'm going to talk about with adults is the resistance for change is also common. And remember, when you're an adult, you kind of have to make those changes, whether you're neurodiverse or neuroexceptional or neurodivergent. You have to make the changes yourself. You have to be willing to make these changes yourself. And it's very difficult because toxic comfort, meaning if you eat foods that it's deemed toxic, at least for your well-being, it's still very, very comfortable. So convincing people to make these changes is very challenging, and it's a long process. I'm going to also talk about some of the change strategies I've implemented as a therapist. I am fortunate to be the gatekeeper of the conversation about food, but I'm not the one who does the work. I usually, ask Kaitlin to help me with this, because as you heard earlier, she is quite remarkable when it comes to make the transition from food becoming a problem for the day-to-day habits of a person, and then creating clarity of mind, or creating a better way of being, improving your mood, improving your concentration, your energy once you've changed that food. But let me start with the nutrition habits I see in adulthood. So we still have a preference of processed food. Processed food is convenient. Processed food speaks to our comfort from childhood. We haven't changed. We continue on that route. We eat the food and mom and dad put in front of us most of the time, and we continue into adulthood. And that becomes problematic. In a lot of instances, it becomes a problem because when we start trying to identify the problem foods, they are usually those foods of habits, usually starch, sugars, and you name it, Repetitive foods is also a problem, focusing on just having the same repetitive habits around food is continuing into adulthood. We also have sensory aversions. They don't disappear. People have tremendous aversion for food. It can be texture. It can be. Kaitlin mentioned, the position on the plate. Like I see that into adulthood. It continues and never stops. Safe foods are also a problem. We only focus on foods that are a certain color, a certain brand of food. We are restricting our eating based on habits, habituations, things that have been happening since we were kids and that were not necessarily changed. What else? There's another problem that happens when we enter adulthood, is after years of consuming psychotropic medication and other medication, we have disruption in hunger cues because of the medications. We no longer, these adults sometimes don't have the ability to recognize the signals that the body sends us that the food is either toxic for us, or we shouldn't consume it anymore. It's like it's as if your intestinal tracts are numb, and then you can't read the interoceptive signal. You cannot read from within anymore whether the food is good for you or bad for you. So the anger cues are affected by the disruption, by medication, but also by stress. By stress in a variety of ways. Being very sedentary is actually an inflammation for an adult. We are, when we sit, we build more cortisol and all of the above, which again affects our well-being. Nutrition habit also ends up being a lot. I hear a lot of reports of mindless eating, like people do not ritualize food in any other way than I've got to take care of it, it's done, or it's emotional eating. It's never food where we sit at the table, we take the time, we observe what we eat, we prepare what we eat. Oftentimes, unfortunately, it's just, it's quite the opposite. It's feeding with the purpose of just feeding, and then usually, it's not feeding the whole body. It's not being nutritional. What I hear from my clients is they're really feeding just the mouth, meaning we want salty and sweet things, and that's it. We stick to the mouth, to the taste buds, not trying to pay attention how it affects us. And usually, I hear a lot of clients talk about, issues with digestion, but what do? We take medication for this. Issues with all sorts of gastric issues, but they're countered, including heartburn. They're countered with other more medications, which further disrupts, the hunger cues that we're supposed to listen to and be receptive to. I hear also body image issues. There's a lot of body image issues. Currently, I have 3 clients who identify as female in my caseload, and body issues are prevalent. What else? And there's so many more, and I'm not going to give you a long list, but the nutrition habits I hear have not changed from the teenage years, or have not been addressed, and therefore have not changed since the teenage years. And all of these as a therapist, they affect your mood, they affect your energy, and they affect your cognitive functions. This is across the board, constant, So the resistance to change is also a huge problem. The number one resistance to change I see is related to executive functioning skills. Executive functioning skills sometimes can be delayed, and when they are delayed, we don't necessarily seem to express an interest in changing our food habits, because undertaking a change of diets is really a huge experience, a huge commitment. And I don't see this with neurotypical clients any more than I see this with neurodivergent clients. But it's just still the resistance to change is much more amplified with people on the spectrum. So some of the reason why we're resistant is just again ineffective executive functioning skills, which I work on. Like how do we plan to change food is a whole protocol where we need to work on that aspect. Emotional attachment to food is also a factor in the resistance to change. People are attached to their food. I am attached to my food. For instance, I know that when I'm sick, I will eat exactly what my mother used to make me when I was a child. Like I go straight to the same thing, minus the meat, because I don't eat meat anymore. But when I talk to my client, it's the same thing. When they're sick, they eat certain food. When they're happy, they eat some certain food. When they're concerned, they eat certain food. And that some of these food, a lot of them, like it was mentioned earlier, they only satisfied your taste bud. They're painkillers. They're not actually nutritional foods. Others are resistant to change is fear of food. Anxiety, body image concerns. The list is very, very long and very, 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 very varied. And I hear that constantly. One of my cases that I find the most intriguing that I worked on with on about 2.5 years, I met a young man who had refused to eat for 12 days. So he was experiencing what's called orthorexia. He wanted to eat clean food, and he refused to eat for 12 days. So he drank coffee and water for 12 days. And then when he started to refeed, he went for sweets. And that was catastrophic. Like it had tremendous physiological problems. He had to be hospitalized and all of the above. When I meet him, it's a few months later, he still does not want, he still want to eat only clean food, just clean food. But he's also stuck at home. He doesn't work, and he's a bright young man. He's extremely intelligent. He doesn't understand. He claims that there's no meaning to life. So when I meet him, we start, trying to understand what's going on. But food was essential for his sort of cognitive decline. His self-concept had changed because he had done something. He had damaged his gastric system. He has damaged his own relationship with food by simply not eating for 12 days. And it was an experiment. We gradually went back to eating some traditional food. And I'll be honest with you, even though I'm trained as a functional nutritionist, this is not how I approached it with him. It was more like, it was trial and errors, seeing like he refused to take supplements because he was concerned that the supplements had been in chemical plants where it might have been produced along other toxic things. Like it was very, very difficult. The only thing he got to eat at the very beginning was raw meat that was prepared with a little bit of I don't remember what it was, but it was essentially raw meat. He only ate raw meat, and it was very difficult. And I will spare you the details, but he was a young man who was 5'7", I think 115 pounds when I first met him. Now he's 5'7", 150, and I do not know how it happened, but he started to feed. He had claimed that he had an addiction to marijuana when he was younger, and he believed that marijuana had an effect on his eating habits. And I accepted this because when you're a therapist, you really have to start where your client is, and therefore you accept whatever they tell you. But strangely enough, after a month of talking about eating habits and such, he missed marijuana, but he didn't want to touch marijuana. So I talked about the gesture of smoking itself, and I do not understand what happened, but he introduced nicotine to his routine, and for some reason, introducing nicotine, then we started going out and eating out together. I took him to a Mexican restaurant, and he was not reluctant to eat Mexican food. And then we started his palate started to grow. And again, there's nothing really scientific. For me, my goal really was to get him out of the house, to start to see that the world existed and he could interface with the world. And then I'm happy to say that now it's 2.5 years later, he has a girlfriend, which he refused to. He disliked himself because of his physical appearance. There was also a case of a body image issue. In addition to, he eats normal meals. He has 2 meals a day. He will never do 3 because he doesn't care for too much meal. Orthorexia is no longer a problem, but and he's employed. He has a job, and it was all around food. Now he is kind of a case that's the opposite of what I usually see in adulthood, because what I see with adults on the spectrum who have issues of feeding is usually early stage of obesity. And that becomes a huge problem because we have, pre-diabetic diagnosis in the early 30s and sometimes like 20s. So we need a lot of intervention at that level. So the other thing I want to talk about is what the positive changes, I try to implement. And they're focused mostly on mindset change, you know, really slowly, gradually. Adults on the spectrum are late bloomers. We blossom at our own pace. It's not meeting any of the milestones the way typical, you know, neurotypical adults will meet their milestone. So the emphasis on being extremely patient, extremely focused on small increment changes is very important, but it works, you know. So the changes I try to implement is focusing a lot on executive functioning skills, you know, learning to change our lives, our life routines through new improved sets of executive functioning skills. I mean, including teaching someone to cook meals. One of my favorite things to talk about, strangely enough, is using an air fryer or using a panini press to start making our own meals, so we know what we put in our mouth, as opposed to going to fast food restaurants and on and on and on. So so some of the positive changes, I also try to teach people how to listen to their body when they eat foods that are not really good for themselves. Like, for instance, if you become aware of the response inside, you might be willing to change your diets more frequently. And I see this. Like, one of my clients, he had noticed that anytime he ate sugar, he would feel pressure in the back of his head. And I didn't question it. I'm like, this is, you know, and so I go into conversation, you know, do you enjoy feeling that pressure in the back of your head? No, I don't, you know. So maybe we can reduce the consumption of sugar, you know. And the reduction of anything, the removal of anything is always progressive. I don't jump to a plan that's too fast and too furious, because the habits and habituations have been going on for so long. I can't do this, you know. So the concept here is, like, we have to change from nourishing ourselves from our mind, what we believe, our beliefs about the food, and then starting to nourish ourselves from our body, what the food does to ourselves. I mean, oftentimes these young men, I have a young man, when he comes to my office, we have 15-minute session, he has to use the restroom 2 times in a 15-minute period. And he constantly has to urinate. And he constantly eats sugar, and he constantly eats starch. He is one of my hardest cases, because even though he understands at the psychoeducation level all the parameters that would help him improve his diet, he is not willing to implement them. And so there's this sort of resistance to good, comfortable habits I have to constantly fight for. But what I would want to see is, and I'm glad that all the other presenters are focusing on pediatric nutrition, because it really needs to start at this point in time. Because when I get these young men, it's so hard to change habits. It's extremely hard to change habits. And no matter what the method, now the one thing that I know is I won't give up. So I help them change by never giving up. But it has to start earlier. And then I will conclude, because I'm just running out of steam, to be honest. I will say one thing. The kids often parallel the eating habits of the parents. And in my coaching, I triangulate with the parents. And I have observed that when the parents are participant in the changing of the diet, you know, the adult on the spectrum will also be more likely to change their diet. The parents oftentimes are responsible for what's in their pantry. If the parents change what's in the pantry, and then if there's a sort of a response, a panic response from the adult, then I can have a conversation. Mom and dad are doing this. They're making the changes in the pantry for the benefit of everybody, for their benefit and for your benefit. So I'm engaged in the family dynamic to try to create a new form of relationship with food, with nutrition, that's focused more on the response of the body and not the need and the wants of the mind, you know. So if you have more questions about being an adult, being on the spectrum, and struggling to change food habits, you can talk to me. It's a very hard journey because we're talking 20, 30 years of habits. But it's worth changing. I've seen people changing their lives, changing the way they think, changing their response to stimuli, getting jobs and getting boyfriends and girlfriends in the process, you know. But thank you very much. And I hope I didn't overspeak or talk too much. I apologize.
No, that was very interesting and good. I liked your examples of that. But really, when you were talking about the parents, there was a question that came in earlier today, and I just want to kind of end asking all of you this question because we are a little over time. But
Sorry.
you know, no, I mean it's okay. I think everyone was giving such great information. But someone asked, how can a parent who's dealing with food insecurity and poverty apply and all these things we've talked about when they're not able to consistently provide the same food at home? And like you had talked about getting the parents involved, I mean, if they're having all these other issues, what are some suggestions any of the speakers might be able to provide for this person who I've made wait for like an hour to ask this question? Does anyone have any suggestions?
I would say, you know, generally just start the way we work within the limitations of preference and, you know, anxiety. We also have to work within financial limitations. And so with everyone I see, you know, it's always just about making one small change at a time. No one expects a kid or an adult to go from this super picky restricted eater to having this explorative palate overnight. So just start making little substitutions where you can. And if you can just replace snacks with things like fruits and vegetables, you know, those aren't like abhorrently expensive. That's something that is affordable from everybody or for everybody. And yeah, so I would say just start making those small changes, and hopefully it'll kind of build and have that snowball effect for you.
Yeah, that's a good idea.
I mean, Whole Foods is really the plan. And the SNAP programs still have pretty good discount on Whole Foods, but it's transitioning from processed food to Whole Foods. That's a giant step. You know, eating a salad versus eating chicken nuggets is a huge difference. Or the sources of protein that are available when we are, you know, struggling with money are usually the processed sources of protein, and they're more problematic. But starting with Whole Foods, this is where I would go. But I'll have to be honest, most of my clientele is not in that situation. I haven't worked with people who have, you know, who struggle having access to food in a long time since I was in school, you know?
Yeah. Okay. And then someone else, just one last question. How can you go about getting allergy testing? Like, who do you need to talk to? How do you
Kaitlin.
Kind of go through that process?
Definitely reach out to me directly. I think my contact info is going to be provided, but my email is info@biomeasd.com. Feel free to reach out at any point. You can also request, you know, this kind of testing through your PCP or your regular doctor, but those requests aren't always granted. So I get a lot of those calls, people reaching out, and you know, they just can't get the testing done in their conventional model, and so they reach out to me, and yeah, I'd be happy to order that for anyone looking for it.
Well, one last thing I want to say, I hope, you know, I don't want to give the impression that I put a lot of the responsibility on the parents. You know, the other day I spoke to the mom of a kid I've seen for years. I've seen him since he was 9 years old. Now he's 14 years old. And I had to explain to mom and dad that right now what's happening, it's not autism, it's being truly a teenager. But since they have dealt with a lot of issues since he was 9 years old, it feels like it's an extension of something that's been already like the teenage years. And so I understand the burden on the parents having to accommodate, having to improve situations constantly since the kids were younger. But that's why I practice, and this is why Kaitlin and we practice triangulating with the family. Like, we are involving ourselves in the families, because then it feels like they're relieved, like they feel like the burnout is less likely to extend another year, another 2 years. I think it's important to be involved with the families, in my opinion.
Yeah, I think it's really good to end on that, having the families all involved with all of this that we've talked about. And I want to thank you all for joining us to give these great presentations. There was a lot of good information, and thank all the people who have logged on to hear it. And as we said, we will have a recording available, and so watch our social media sites so you can see when it is. And anyone who registered, we will be sending out contact information for all of the presenters and copies of slides and articles and things that they have provided us so that you can have all of that. And we will look forward to seeing you all at the end of February. We're still designing that program to see, we have a couple of topics we're kind of bouncing around and seeing who can commit to it before we tell you what it is, but it's going to be that last week of February. And we're going to hopefully, I can't guarantee it, but we're going to hopefully try to have one in person so that we can all kind of see each other, which I know gets you a little more interactive than you can on Zoom. So we look forward to seeing you next month, and thank you all for joining us, and have a good night.